happy to introduce this session and to moderate it. Just a couple of brief comments real quickly. So we'll be, this is our first Cleveland Clinic ECMO Journal Club, and we'll be talking today about a couple of trials. Next slide. So I'll be moderating the session, and we have the distinct pleasure of Dr. Sudhir Krishnan to present the two papers. Next slide, please. And just a couple comments about CME and then about the platform. So at the conclusion of this presentation, this discussion is approved for CME. So as is shown on this slide, at the conclusion of this or at some later point, you can jump on to my CME and search for ECMO Journal Club and get credit for participation and attendance with the session code that you see described there. And then one quick mention about the platform. So just to recall, this is a Teams platform, so it is interactive. So if you have your mic unmuted, everyone can hear. So perhaps during the presentation, everyone can mute themselves, and then afterwards to ask questions, you can unmute. So with that, I'll leave it up to Dr. Krishnan to present the papers and open the discussion.
Good evening, everybody. It's truly a pleasure to be here this evening. I want to give a shout out to Alex, Penny, and Donna for organizing this. Kudos to the three of you. Thank you for taking the initiative to make this thing happen. So also to all the intensivists and the nurses in J5 and J3, congratulations on the Center of Excellence Award. This is a testament to all that you do every single day. I know how hard it is in J5, so truly kudos to you. So I was asked to present CESAR and EOLIA. It's been a few years since these papers have come out, but I think it's still pertinent now in this COVID times. So the idea is to ECMO or not to ECMO, CESAR and EOLIA. So mortality in ARDS is high, it's about 60%, depending upon the papers that you read, and the numbers consistently so here at the Cleveland Clinic. Having said that, we've noticed something different during the COVID times, and I'll get to that in a minute. We know that conventional mechanical ventilators can exacerbate lung injury in ARDS if one were to use high inflation pressures. We also know that ECMO allows for gas exchange in an extracorporeal circuit, and allows for us to mitigate the inflation pressures on the mechanical ventilator. Now, before the CESAR trial, there were only just two randomized controlled trials, one going back in 74 and the other in 1994, which actually showed harm because of ECMO. But the observational studies in the late 90s showed varying survival rates, some as high as 66%. So ECMO was a UK-based study, and it looked at three things: the safety, the efficacy, and the cost effectiveness of ECMO as compared to conventional mechanical ventilation for the management of respiratory failure. This was a randomized controlled trial with a 1:1 ratio of conventional ventilation versus ECMO. The researchers were blinded at 6 months follow-up. However, the clinicians and nurses were aware of what the therapy was, which was pragmatic. Now, the authors of the study assumed a mortality of 65% in the conventional group, and this number was borrowed from the NIH ARDS network data. And they anticipated a reduction of 20% by use of extracorporeal life support, and they came up with a number of 90 in each arm to proceed with the study. This was an intention to treat analysis. And the idea behind that is if a patient is randomized to whichever arm, he or she gets analyzed in that arm. So if you get the treatment, don't get the treatment, you're still analyzing the arm. Setting, like I mentioned, was a UK-based study. There were 92 conventional tertiary ICUs and 11 referral hospitals that participated in the study. But there was only one designated ECMO center, and all these patients were transferred to the Glenfield Hospital. The study was conducted over a 5-year period between 2001 and 2006. The primary outcome was death or severe disability at 6 months, and severe disability was almost a moribund status, wherein the patient was unable to look after himself and was bedbound. The secondary outcomes included use of adjunctive therapies, mechanical ventilation, HFOV, use of nitric oxide, use of steroids, prone ventilation, and health status. The inclusion criteria was a Murray score of 3, and to the left of the screen, or to my right rather, you will see the 4 variables that go into calculating a Murray score. And we still use the score here in our institution to select a patient for ECLS, a pH of less than 7.2, be it metabolic or respiratory. And they had strict age criteria, 18 to 65, upper limit being 65. Exclusion criteria: if you had high inflation pressures or high FiO2 for more than 7 days on a mechanical ventilator, you excluded. Intracranial hemorrhages, contraindications to anticoagulation, and planned limitation of support with the other exclusion criteria that were listed. So the intervention was transferred to an ECMO specialist center, and Glenfield had its own retrieval system. But no patient was committed to ECMO prior to transport or during transport. Once they reached the center, they were all committed to conventional therapy, which included mechanical ventilation, limiting the plateau pressures to less than 30 centimeters of water, optimizing the PEEP, optimizing the FiO2 to maintain SATs of 90%, diurese, use pressure control ventilation when possible, and utilization of prone positioning, similar to our protocol here in the medical ICU. You were cannulated if there was no response within 12 hours, and this was a percutaneous cannulation, FEM-FEM or FEM-IJ. Non-responders who got cannulated patients were deemed to be non-responders if you had an FiO2 of more than 0.9 or SATs of 90%. You were hemodynamically unstable with a pH of less than 7.2 after treatment and therapy. The intervention on ECMO was they used roller pumps and they used polymethyl pentene oxygenators, the Medox oxygenator. And they continued with treatment and therapy till such time as the patient recovered or there was irreversible multi-organ failure. They diuresed the patient to dry weight, and the ECT was maintained between 160 to 220 seconds. What was interesting was hemoglobin was kept at 14 grams per deciliter and platelets were kept at over 100,000. Now, MARS is a molecular adsorbent recirculation system. It's an extracorporeal circuit that essentially clears your blood of bilirubin, and that was liberally used in this group, and I'll tell you the numbers shortly. Now, the control group had conventional mechanical ventilation, and they used either pressure control mode or HFOV. But what caught my attention, and I'll mention that soon, is only about 70% of patients in the conventional arm truly had lung protective strategy. And the duration of conventional mechanical ventilation was for a period of total of 15 days. The CESAR trial did not allow for crossover. So if you deteriorated on conventional mechanical ventilation, there was no exit strategy. It was essentially death. Now, they initially started out with 766 patients. On the left side, we'll have ECMO numbers coming through, and on the right side, to my right, you'll have numbers coming up for conventional ventilation. There were 90 patients assigned to both groups, but here's what should catch your attention. Out of the 90 patients who were transferred to Glenfield, 16 improved with conventional management, and 5 died, and there was a contraindication to heparin. So only about 68 patients ever got extracorporeal life support. And this has a huge bearing on the outcome of the study. 90 patients end up getting conventional and mechanical ventilation. 33 patients died in the ECMO arm. 44 patients died in the conventional therapy arm at about 6 months. But only about 52 patients ever followed up in the ECMO arm, and number was lower in the conventional arm. There was a lot of follow-up. Now, I've circled this number over here. 3 patients withdrew from the study, and this has implications on how the data was assessed. 3 patients withdrew from the study, and that information was not available. Having said that, this is the table 1 in the CESAR trial, and for convenience sake, I've just put the the variables that are relevant over here. So there are 180 patients, 90 received conventional therapy, but only 68 of the 90 received ECMO for reasons mentioned before. The mean age was 40, predominantly men. The primary cause was pneumonia, about 2/3 of the patients. The ventilator duration was less than 7 days in 93% of the patients. Now, the PF ratio was 75 millimeters of mercury. Now, the P to F ratio, 75, what I would like to remind everybody, that's a really low number. So you take any study that's been published in critical care literature with regards to PEEP and mechanical ventilation, it'll be unusual for you to find a study with PF ratio less than 100, be it OSCAR or OSCILLATE with HFOV studies or the EXPRESS or the alveoli study for PEEP. These numbers are really low. And the Apache 2 score was 20, and I calculated the predicted mortality at 24% at the time of entry into the study. Now, a third of the patients, the data was missing, and a lot of imputation was done, wherein which mean values for a specific variable, if it was continuous, was used to compute the data, and this has bearing on our on how we assess the data and the inferences that we draw from the study. So this is finally statistical analysis. To the left, you have your data. To the right, you have the author, and you're looking for the elusive p-value of 0.05. And this was the intention, like I said, the primary analysis was intention to treat. So if you were recruited to the ECMO arm, and you would be analyzed in the ECMO arm. And if you were recruited to the conventional arm, no matter what happened, if you did or did not get the therapy, you would be analyzed in the arm. And then you did a parametric or a non-parametric test, depending upon the kind of data that you had, to come up with your conclusions. And this was an easy win. We have an absolute risk reduction of 16% with a p-value of 0.03. This was a positive study published in the Lancet. And the inference drawn was death or severe disability at 6 months. There was 16% absolute risk reduction by using ECMO with a number needed to treat 7. Now, what I really want people is to understand what this p-value means. The p-value is a measure of the effect.
That I was supposed to be.
The p-value is a measure of the effect of chance within a study. It is not the probability that the result of the study is true or correct. And what it essentially says is that if for whatever reasons ECMO did not result in the survival benefit that you see, the chance of that happening by pure chance was less than 3%. The primary outcomes, continuing with that, what I wanted to impress upon everybody was 17 out of the 85 patients continued to receive mechanical or conventional ventilation rather than ECMO. 14 of the 17 patients actually survived. Now, these patients had come to Glenfield expecting ECMO, but did not get ECMO. In fact, they improved with the conventional therapy, and 82% of them survived. But they were analyzed in the ECMO group. Some patients had some degree of disability at the point of discharge and at review at 6 months. And there was just one person who had severe disability at 6 months, wherein which he was bedbound. Now, data for 3 patients were missing in the conventional arm. And here's the problem with this. If you assume that these 3 patients died, then suddenly the p-value magically changes to value of 0.51, which will make the study, essentially by frequentist method, questionable. The ICU length of stay and the median length and the hospital length of stay for the ECMO group was longer, but this was not statistically significant. And there was an exhaustive checklist of things with regard to quality of life, anxiety, depression, functional status. It was a comprehensive assessment. There was no difference between the 2 groups. This was the secondary endpoints, ECMO versus conventional therapy. There was no difference in prone ventilation or use of HFOV. But there was liberal use of steroids in the ARDS group in 2001-2006. MARS, like I mentioned before, is an extracorporeal therapy used to clear the plasma of bilirubin in patients with liver failure. And what is interesting was 15 patients had this therapy, which I found very interesting. But there was no difference between the renal replacement therapy or use of nitric oxide in these 2 groups. One of the interesting aspects of the study was the strict review of the economics of ECMO. And what they mentioned was there was a gain of 0.03 quality adjusted life years at 6 months. Let me explain this to you, the way I understand at least. So right over here is death. And at 1 is perfect health. At 0.5 is you being up and about. And 0.7 and 0.8 is you up and about walking freely. That's utility value. And on the x-axis, you've got the number of years. Assuming you have a disease, a pathology, and you were treated with some treatment or therapy, and then it allowed you to function at the level of 0.7 and gave you 3 extra years, you got a quality of 2.1. All right. So the current standard of care is 2.1. And then you could have another treatment or therapy now, a new treatment or therapy that could improve your functional status and improve your quality. So you gain functional status. Or you could have increase in the number of years that you're going to live. And that again is increase in quality. So either your functional status improves or the number of months or years improve. And at 6 months, we had a gain of 0.03. Not a lot, but it is what it is. Now, what we also had was cost effectiveness. Now they calculated the cost of ECMO, and it came to about $40,000 mean. And the question was, is it cost effective? And this is the formula that they used to come up with this this magic number. Now, this is the NHS, Socialist Form of Medicine, and they felt that this therapy, the cost of this therapy, was cost effective, and that's how it was listed in the paper. Conclusions drawn from the CESAR trial. What they said was, we recommend transferring adult patients with severe but potentially reversible respiratory failure with a score of more than 3 or a pH lower than 7.2 to a center that has ECMO management. And now here the strengths of the study. Now we had early assignment to those treatment groups. It was an intention to treat analysis. So all those patients who were recruited to the study did get analyzed. Having said that, there was some loss to follow up, and that affects an intention to treat analysis. They incorporated a transport risk into the trial design, and this was used when they analyzed the data. There was robust economic analysis, and a page is dedicated to just that. There was 6-month follow-up testing to look for post-ICU syndrome and long-term effects of extracorporeal life support. But here are the limitations of the study. What the study was not an absolute comparison of ECMO versus conventional ventilation. What it was a treatment in a single specialist center with the potential for ECMO versus standard UK treatment. The problem is, but 24% of the patients did not receive ECMO. It was not the Wild West, but they did lack a management protocol, and we'll discuss that when we talk about the EOLIA trial. There's missing health evaluation data and representation, which added to the confusion. Those 3 people who withdrew from the study, if their information was available, then the results of the study could have been something completely different. This study was an intention to treat analysis, and it's only good if there's minimal loss of data. And then follow-up information was available only in 58% of the ECMO patients and 36% of the patients on conventional mechanical ventilation. So if one were to take home message would be the study supports ECMO as a valid treatment, but it's questionable if ECMO is better than conventional ventilation, and that's what was being asked over here. There's incomplete follow-up data, and it's difficult to generalize. 24% of the patients who were initially assigned to the ECMO group did not receive ECMO, which is a point of contention in the study. And it brought forward the importance of specialist units and management in a tertiary care center. Effective lung protective ventilation can save lives. We did have a significant proportion of patients with conventional ventilation who actually survived this treatment and therapy despite a PF as low as 75. And ECMO is an option in patients with refractory failure. But it remains unclear if ECMO improves outcomes as compared to standard treatments, including protective lung ventilation, proning, and recruitment maneuvers. And that doubt remained and persisted. The segue to the EOLIA trial, 2012-2017. Now, this was a study that came off the results of the CESAR study. And by then, we had major advances in the circuit. We also had results of the H1N1 pandemic, and it appeared that there was an observational benefit. There was a benefit of ECMO in these group of patients. We also know that we had some amount or limited information from the CESAR study. And the idea behind the study was to see the effect of early initiation of ECMO in patients with the most severe form of ARDS. So initiate ECMO upfront and initiate ECMO early. So this was done in France. There were 64 centers. There were two international centers in University of Maryland and University of Columbia contributed to the study, and the University of Toronto. There were a few non-ECMO centers, but they were deemed to have significant ARDS experience. And the primary outcome was a 60-day mortality. Secondary outcomes include treatment failure at 60 days. Now, treatment failure was described as, in the conventional arm, was transition to ECMO or death. ICU length of stay, days free of mechanical ventilation, and day free of renal replacement therapy. Now, this again was a prospective randomized controlled trial. McCurry or Gettinger was a sponsor, but they had no say in the trial design or the results of the study. The research staff was blinded, but the clinicians were aware. This was a central web-based randomized process of allocation. Now, they targeted a total of 331 patients, and this was targeting an absolute risk reduction of 20%. They estimated the mortality in ARDS to be about 60%. But here's the catch: if they would have if they had gone off the CESAR trial and they said absolute risk reduction was 16%, or they dropped the value down to 10%, and they would have gone off with the 50% mortality observed in CESAR study, this number would have changed dramatically. Now, the recruitment of the study was very slow, and the DSMB recommended stopping the trial at the 4th interim analysis, and by then they had recruited about 249 patients. The recruitment was very slow. It was about 1 or 1.2 patients per year per ICU. And they did very sophisticated analysis to adjust for the crossover. So when you have an intention to treat analysis, which it was, one has to account for the crossover that they permitted. And we'll discuss that in a minute. So inclusion criteria again was mechanical ventilation less than 7 days, an FiO2 of a 0.8 or 80%, P for more than 10. They had to have lung protective strategy, and they had to fail adjunctive therapies before being considered for ECMO. Your PF ratio could be less than 50 for 3 hours, for more than 3 hours, or a PF ratio less than 80 for more than 6 hours. Or your arterial pH is less than 7.25 and a PCO2 more than 60 for 6 hours. And then you had to have one of many adjustments made to mechanical ventilation, and then one would consider. And this has been our criteria for recruitment since we started this program. You were excluded if you were aged less than 18 and mechanical ventilation for more than 7 days. We have made provisions for some patients. Our BMI is slightly on the higher side. End-stage lung disease on NIV is a no. Malignancy less than 5 years. SAPS2 of more than 90 predicts a 90 plus mortality score. Obviously, difficult vascular access, coma, HIT, and VA ECMO were exclusions. So the intervention, this was again a percutaneous cannulation, FEM-IJ. ECMO parameters were adjusted to maintain a PO2 between 65 to 90 and a PSO2 of 45. The vent was adjusted to low tidal volume ventilation with a P-plat or plateau pressure of less than 24 and an FiO2 of less than 0.5. And the APTT was kept between 40 and 55, which is about 1.3 times the normal value, so low anticoagulation. The conventional therapy of the control arm again had lung protective strategy, but there was use of neuromuscular blockers, prone position, and recruitment maneuvers as if and when required to be. Adjustment of the respiratory rate was made to, the respiratory was rather adjusted to maintain a pH more than 7.15, and you could use sodium bicarb if the pH was less than 7.15. Now, here's the interesting fact. You could cross over from the control arm to the ECMO arm if your SATs were less than 80% for more than 6 hours, despite use of recruitment maneuvers, prone position ventilation, and use of nitric oxide, provided you did not have multi-organ failure. But here's the catch. the MD had to believe that this could actually change the outcome. So there was some degree of subjectivity to this crossover. Most of the patients, the use of corticosteroid sedation, analgesia, hemodynamic management, and weaning from the ventilator and tracheostomy was left up to the discretion of the ICU and the physicians. So they started out with 1,000 patients, but they ended up randomizing 124 to the ECMO arm and 125 to the conventional arm. But here's the catch. 35 patients crossed over to the other side, and this has bearing when you do an intention to treat analysis. So if these 35 patients survived or they died, they would have been analyzed in this arm, and that would have attenuated the results of the ECMO arm. So this is table 1 from the study, and in the interest of time, I'm just put up the things that matter the most. So mechanical ventilation for less than 7 days, 249 patients were randomized under the age of 60, most of them. The SOFA score was 10.8. The predicted mortality is 50%. The PF ratio was 72 to 73, slightly lower than CESAR, but just to mention that this is patients who are really sick. Bacterial pneumonia was the most common etiology for the ARDS, but otherwise there were no obvious differences between these two groups. Coming back to statistical analysis across over here, data to the left and author to the right, and we're still looking for the elusive p-value, seeing if in case there's an actual change in the outcome. We used an intention to treat analysis, and the rest of the tests were done depending upon whether they were categorical or continuous and whether they were distributed normally or not. But here's a catch this time around, and I'm happy with the results that came through. We showed an absolute risk reduction of 11%. But unfortunately, the p-value is 0.09, and this is what you see on the Kaplan-Meier curve. So the final analysis was the death at 60 days. We noticed an absolute risk reduction of 11%, but the p-value was not to our liking. That essentially making it a negative study by the frequentist method. But here's the cool fact. The secondary outcome, that is the relative risk of treatment failure. So in the conventional arm, treatment failure was deemed as death or crossover. And in the ECMO arm, treatment failure was deemed to be death. And you know for a fact that the number was on the lower side. So there was a 38% absolute reduction, or 38% reduction in the relative risk of you dying if you're on the ECMO arm. A cool fact, if the authors, if this was their primary outcome, if they would have labeled this as a primary outcome, this would have been a positive study. They chose to mortality at 60 days as a primary outcome, but if they had gone back in time and chose to use treatment failure, then the way the paper would have been presented would have been completely different. But the risk of renal replacement therapy was also lower in this group. And the ECMO patients underwent less proning too. So secondary outcomes were favoring ECMO. And this graph just essentially lists the table rather lists the same thing. So lower renal replacement therapy, lower use of pressors, and days free of mechanical ventilation. What was the single most important thing about the study, to what caught my attention, was how well the study was done, and the fact that unlike CESAR, we actually had a list of the adverse events that happened, and I perused through CESAR, both the actual document and the supplement, and there's no mention of adverse events in the CESAR trial. But over here, we did have a few cases of thrombocytopenia. There were high incidence of bleeding events in the ECMO arm, and bleeding event was defined as requiring 1 unit of blood transfusion. Thrombocytopenia was values less than 20,000, but low risk of stroke, which was phenomenal. But interesting facts about the patients who crossed over. There were 35 patients who crossed over, and that accounted to 28% of the actual size of the entire conventional arm, and they crossed over at a median at 4 days. But at the time of crossover, their PF ratio is 51. Remember that the conventional arm had a PF ratio of 75 at the time of randomization. So by the time these patients were moved from the control arm to ECMO, they were very sick. SATs fell up to 77%. The lactate was creeping up. 9 patients had a cardiac arrest. 7 had right heart failure. 11 ended up receiving renal replacement therapy. 7 ended up having VE ECMO. 6 of them having ECPR. It's no surprise that the 60-day mortality for this specific group of patients was higher as compared to the others in the conventional group. So more than half of the patients died. But what the authors did not do was there were a select patients who directly were randomized to the ECMO arm with the PF ratio of 51. And what would have been interesting is if they would have compared these group of patients to those ECMO patients with the PF ratio of 51 millimeters of mercury. That would have been an interesting thing, but that never happened. Again, this was an intention to treat analysis, but there was crossover, and that leads to a certain degree of bias because essentially what happens is be it the survival or the mortality that happened because of ECMO would now be attributed to the ECMO arm, to the conventional arm rather. So we had to come up with something different. And then we had to use a rather sophisticated tool called the rank preserve structure failure time model. Now, I attended a webinar that Alain Combs gave talking about this EOLIA study. He didn't spend a lot of time discussing this model, but it is frequently used in oncological trials when there's a crossover from a control arm to a therapy arm, and it kind of accounts for this crossover. I have a slide at the end of the presentation. If someone wants to know in detail, we'll discuss about that. But this was the author's last attempt at trying to find the elusive p-value, and as hard as he tried, we noticed truly the ECMO group had higher survival, but in the purist would argue that the p-value is less than 0.05 or comes very close to it, still negative. So the authors at the end of the study kind of concluded that ECMO for severe ARDS showed no significant benefit in mortality at day 60 as compared with conventional mechanical ventilation, and has included a crossover to ECMO. And ECMO was used in 28% of the patients in the control group. Strength of the study, this is the largest multi-center randomized control trial for ECMO ever between 2012 and 2017. I was told by Giles Peak when he visited that a significant amount of money was spent for this trial. It's unlikely it's ever going to be repeated again. They had standardized criteria for entry into the trial, and they actually had a criteria for rescue, which CESAR did not have. Every patient who was randomized to ECMO received it, or most patients did. The allocation was concealed. There was protocolized delivery of both of ECMO and mechanical ventilation, and that was standardized therapy, and that wasn't the case in CESAR. But here are the limitations of the study. Can you truly draw conclusions from an underpowered study? An underpowered study almost always overestimates the effect size, but it's the best that we have. Like I mentioned before, CESAR trial showed an absolute risk reduction of 16%. The mortality was 46%. And maybe if they would have adjusted for the values observed in the CESAR trial, maybe they would have needed a smaller number and maybe things would have looked different. Now, what was most interesting is that 28% of the patients crossed over to the ECMO arm, which diluted the results. But the problem was the patients who crossed over were sicker and more than likely dying and going to die. And it was a discretion of the physicians. There was some degree of subjectivity that crept into an otherwise well-done randomized controlled trial. It was 249 patients with a course of 6 years with very slow recruitment. And one could argue that the PO2 of less than 80 millimeters of mercury for more than 6 hours, it could be a liberal criteria. Now, the external validity, does this apply to every center? It all depends upon the center of the ECMO. And does the configuration have any role to play? Doubt it. But in COVID times, can you extrapolate the information that you have from the CESAR study where the patients were predominantly male had bacterial pneumonia and septic shock? A small proportion of patients with septic shock. So what does one take home from that? Early initiation of ECMO did not improve 60-day mortality in the true sense, but you cannot, as an ECMO enthusiast, it's tough for you to ignore the fact that there was a 11% absolute reduction in mortality. And the fact that those 35 patients, there was just no way any one of them would have survived had it not been for ECMO. But this possible clinical benefit from ECMO was standard care if used early. And the reason we say that is because we noticed lower organ failure in those patients who were transitioned to ECMO upfront and up early. And this is something that caught my attention too. We know from the neuromuscular blockade study, a curious study before the ROSE trial showed a mortality benefit in patients, in hospital mortality. And the argument was that you're preventing multi-organ failure later on during the course of the patient's hospital stay that's responsible for this increased benefit that you see. So, well, no organ failure up front, always a good thing. What was also evident was the high rate of failure of conventional therapy requiring rescue. Remember, 28% of the patients moved from the conventional therapy to the ECMO arm. So, but at a PF ratio 75, those of us who are here in the medical life should do this on a daily basis. We know for a fact that there's a threshold beyond which for a fact that the mechanical ventilator will fail. But I will leave. But I'll have the editor of the New England Journal have the second or the third last word. So ECMO probably has some benefit in this context. The trial is not traditionally positive, and most of the secondary outcomes actually favored ECMO. This was an editorial that accompanied the actual study. Here's my 2 cents, and here's how I look at it. ECLS did no harm. It improved mortality. It utilization of extracorporeal life support resulted in a mortality benefit. ECLS or ECMO can be delivered safely. There was lower organ failure in the ECMO group. Small changes in patient numbers can have profound changes in the p-values. Safe to say that some would not have survived without ECMO. My glass is half full. I don't think I'm going to change my practice. In fact, what this has only done has cemented my belief that there is a group of patients who are not going to survive without ECMO. And across over here at the Cleveland Clinic and in our ICU, ECMO is called for only when the patient has failed conventional therapy. And there's a very strict protocol that's followed. So for the intensivist to call on for ECMO, by then the patient truly has failed every single therapy that we have. Now, for those of you who are remotely interested to know what Planck preserved structural failure time modelers, I had to take a couple of aspirins by the time I was done with this. And I doubt, but this is being recorded, so feel free to take a look at what this is. But this is a survival time analysis that takes into account, the probability of you surviving with or without ECMO. I will take questions if there are any, and I'm happy to answer.
Well, thanks, Sudhir. That was outstanding. So I learned many things during the course of that presentation. One of the most interesting was, I guess you're a cage fighting fan. Is that correct? Which that was completely unexpected.
He doesn't like to talk about Fight Club.
Yeah.
I take it, are you an observer or a participant as well?
No. The idea was, the theme was very simple. Is the things that we do to data to come up with the p-value. That was the idea behind that picture.
Yeah, no, I understand, Sudhir. So we'll open it up for questions. So I think a couple of different ways to submit questions. One would be through the chat or question function on team members, or you could just unmute, announce yourself, and speak up. Maybe I'll just ask a brief question, then everyone else can jump in, Sudhir, if that's okay.
Sure, absolutely.
So, given this, can you give us a little bit of, and this is a little bit of sort of, your opinion, your conjecture, but being a participant and enthusiast, can you give us a little bit perspective on how you think the outlook on ECMO has evolved since 2009, since the CESAR trial finished, and through the advent of a couple of flu episodes and things like that to current day? How do you think it's perceived in the United States and abroad by various programs?
Yeah, Dr. McCurry, the simplest fact is me pulling up the ELSO COVID database right now. We have over 1,400 patients on the circuit right now throughout the world. The horse is out of the barn. ECMO is here to stay. I believe that this technology is an inflection point, and I see the therapy being increasingly being employed in other institutions as they gain experience. There are benefits. I think it can be delivered safely. I believe, with new non-thrombogenic oxygenators, with better diffusion barriers, better motors. In my lifetime, this therapy is going to move out of a cardiothoracic ICU, and it's going to be handled by an intensivist in the years to come. So for me, I'm sold out on this therapy. The ELSO COVID database right now registers a 55 or 60% survival rate. None of those patients would have survived had it not been for extracorporeal life support. We have better anticoagulants. The idea behind a multidisciplinary team is slowly gaining ground. The idea behind lung protective strategy, that's become the dictum right now. So for me, where I stand, our numbers have increased dramatically over the course of years. Our outcomes have remained are as good as they can be. And we take some of the sickest patients. We've taken patients with interstitial lung disease who have recovered. We've taken patients who had underlying malignancies who have recovered. So for me, yes, the promise to the patient is you must fail conventional therapy before I consider you for ECMO. And we are not going to consider ECMO before that has happened. I do not see it as a substitute to mechanical ventilation. I rather see it as a supplement to mechanical ventilation if you fail. And the numbers are there for everybody to see in ELSO database. And the number of centers have increased dramatically. So my 2 cents.
Yeah, I would agree. And just one comment, and then everybody else can jump in. But I certainly would agree with what you espouse. And I think it's notable, particularly for the residents and fellows and other people that have joined in and listened to this, is that, there was a significant inflection point, around 2009. And that's when the number of programs worldwide really increased exponentially during the H1N1 pandemic, and that growth worldwide has continued since then, as you allude to, and technology is getting only better and better and better. Anyone else?
Hey Sudhir, this is Bala. Excellent presentation.
Hey Bala.
So I think the question that whether ECMO works looks like it's been answered and EOLIA will not be repeated. So what are some of the future questions that needs to be answered with regard to ECMO and ARDS? And also ECMO and cardiac failure, there are no studies, at least no randomized controlled trials of this quality answering that question also.
Well, that's a great question. For me as a pulmonologist, one of the thoughts that I would have would be is it possible for us to have a low flow device, that's something that any intensivist would be able to do that works in tandem with lung protective strategy, ultra lung protective strategy, that will allow for early liberation from the mechanical ventilator. That would be the next step for a critical care pulmonologist. For me, as I see more of this, my immediate question would be, hey, listen, can a low flow device allow for ultra lung protective strategy and allow for early liberation of from the mechanical ventilator? That would be one thought. We recently had 2 patients now with asthma, and we use an echo device, and that worked very well. The other thought would be to see these devices as mobile devices, smaller, something that be contained on a patient, mobile ECMO. I mean, that was another thing that as a pulmonologist who deals with end-stage lung disease, could that be something that be a bridge to transplant, a long-term device, efficient oxygenators, use of oral anticoagulants, devices that last for months together rather than days. That now the VA ECMO side, the impression that I got from Giles Peak when he spoke was, these studies are as expensive as they are tough to do. The recruitment is so low. I don't know whether a VA study is possible. But what a fabulous opportunity for someone to take the initiative to take a look at the observational studies and whatever data is available to do at least a systematic review and meta-analysis, and then at least have that information available to justify need for a trial. That's what I would say on the VA side of things. We have a huge database. We have our data. I don't know whether it's been published or not, but my 2 cents, Bala.
Thank you.
Oops. Anyone else?
Yeah.
Penny?
Hi, Sudhir. It's Penny.
Hi, Penny.
Hi, really great talk. Obviously, we're talking about what's the feasibility of doing another study, which is quite difficult, but thinking about operationalizing a new study, if you're, had the luxury of doing that, what would outcomes be for you? How would you think about designing it based on the limitations that we've seen thus far?
Penny, I'm sold. Like I said, does ECMO save lives? At the bedside, as a clinician, that question has been done and dusted. That's been answered. I don't think I will revisit that anymore. I don't think I need to do another study or another 1,000 patients. Yeah, could I have another study of 10,000, 15,000 patients? Yeah, I would love to have. Let's be practical about it. I don't see this thing happening. An ideal study would be, for me, would be treatment failure. I think CESAR answered the question that ECMO saves lives in the right clinical context. I'm not saying that use it as to supplant mechanical ventilation. What I'm saying in the right clinical context, patients who are failing mechanical ventilation therapy should have the benefit of extracorporeal life support. And for me, the information that's available is enough. I don't think we need to revisit this thing anymore. It's done and dusted.
What about the potential for when we actually trigger ECMO therapy? We saw very severe ARDS in terms of a trigger. Do you think that there is the potential for a different threshold?
Yeah. Is it possible that, one of the things that caught my attention when Alain Combs was doing his webinar was what he felt, and what he did not mention in the study is he believes that the survival for the patients on extracorporeal life support was higher who began on a PF ratio of 100. You see, so the mean PF ratio on EOLIA trial was 75. But there are no graphs, and this is a conversation he was having with someone. And what he mentioned was that if he had a chance to do this trial again, he would have kept 100 millimeters of mercury as the entry point for this study. But Penny, I'm also aware that, ECLS is not without its complications too. I mean, I'm there at the bedside. You see this thing happening. Like I said, could there be a time when we can deliver this therapy safely without anticoagulation, without the antecedent vascular risks, risk of cannulation and DVT? I would love for all that to happen, but as of now, I would probably reserve it for only those patients who failed conventional therapy, and not necessarily as a substitute to that. And that's the question that they were trying to answer one day. I mean, both the CESAR, the entry point for both the groups was 75 for CESAR, and it was 72 for EOLIA. What we noticed was, yes, the patients on conventional, it's not as if everybody on conventional therapy on mechanical ventilator died. No, there were 38, 35 who crossed over, but 55, 60, 70 patients did survive. So lung protective strategy still works, you see. So for me, as it stands, the EOLIA study is good enough. That's been our criteria for transfers. Are there certain phenotypes? Another interest of mine is now there are certain phenotypes in ARDS we know who do better. And there's a company that we are in talks with to see as to what phenotype of ARDS patient. They have an exhaustive checklist of things that they're going through. And then I asked myself, is there a phenotype that survives ECMO on ARDS? So as of now, our criteria is very simple. You have to fail mechanical ventilation. You have to fail adjunctive therapy. Let me see what your rest score is. Let me see what your preserve score is. What are the chances of you dying right now if I don't give you ECMO? What are the chances of you surviving next 6 months? How bad is your critical score of illness? What does your RB look like? And then you make an intelligent guess. And we have about 150 patients that we have now, a database that we're slowly trying to populate. And maybe in a year or two, we may have a more sophisticated tool to recruit the right patient.
Yes, Sudhir. I'm sorry.
Yes, McCurry.
I was just going to ask along those lines. I mean, do you think there's any other, you know, I mean, the phenotypes and the data that we utilize are pretty blunt instruments, right? I mean, they're gross phenotypes about physiologic function. Do you think there are any other potential biomarkers that we might be able to use to decide who should go on ECMO earlier or later, and who has a better chance of surviving with which?
Absolutely, that's a fabulous question. You know, that's the next level of how we decide who goes in. Like I said, you know, once we know for a fact that IL-6, IL-7, and IL-2 levels decrease. Now we've known this with neuromuscular blockade. The accuracy study, the neuromuscular blockade trial for by the Papazian group for ARDS, the one thing that they consistently looked at, and their study was an evolution over the course of 12 years. And one of the things that they did was they looked for inflammatory markers both in the blood and the BL. And what they showed was, you know, over the course of time was neuromuscular blockade essentially decreases the levels of these inflammatory markers. Now we know for a fact that ultra lung protective strategy allows us to do just that, drop the levels of IL-6 and IL-12 levels. But as of now, I do not know of any study that's been done looking at pre-existing levels of IL-6 either in serum or BAL that can predict either a good or a bad prognosis, and that's fabulous grounds to study.
Yeah. Yeah, it seems to me that would be you know, that would be a very interesting way of looking at and trying to figure out, you know, who would be better off on an earlier than later.
Absolutely, yes. So one could argue that, hey, listen, you know, high levels of inflammatory markers, you know, portend a poor prognosis. We've known that consistently, you know, with COVID and high CRPs. Now, what's interesting about COVID is, I'm just putting it out there, last 5 minutes, is we've had 216 patients who are mechanically ventilated with COVID, and not a single case, you know, that we had to cannulate, which has completely baffled me. On an average, we have over 100 cases of ARDS per year. 30 of them are serious enough, severe enough, and then it's not unusual for us to at least have a discussion about 12 or 15 of these cases. But as of now, and I'm grateful, but it has caught me by surprise that 216 mechanically ventilated patients, a third of them should have been very severe ARDS. But we've only had about 6 or 7 ECMO consults that came through, and none of them triggered any of our parameters to be considered. And there were only 3 or 4 that we turfed because of old age. So I don't know. I think it's probably the exceptional care that has been had here in the region and in the main campus. But that did catch me by surprise. But the point was, yes, high levels of inflammatory markers, rising CRP almost always portends that the lung injury is going to go from bad to worse. I mean, that's something that we fear now. We've had a bunch of patients who were intubated, got better, extubated, the CRP started rising 3 or 4 days, and lo and behold, they were back in the medical ICU tubed again, almost like a second wave, if you recall.
Hey, Sudhir, it's James. Just to play
the
devil's advocate, I know that you and I work with ECMO all the time, and we have pulled some patients out of the fire with ECMO. But you know, if you're a non-ECMO clinician and you look at this study and you say, okay, there's no mortality improvement at 60 days, what's your rebuttal to that in terms of, you know, why would a enterprise want to invest capital and resources in a VV ECMO program when you don't have a study that turns out in a positive light here?
Well, you know, that was simple for me, James, and I would point out the weaknesses of the study, you know, as easy as it is for the physician who argues, says that, hey, listen, this is a negative study. But, you know, what I want to impress upon everybody is this, you know, we are using what's called a frequentist method, or we're using a p-value to come up with the idea that, hey, this test is negative or positive, you know. But what I really want us to ask ourselves is the p-value of 0.05, is it, and 0.07, how far is it away from 0.05, you know? Is that grounds to disregard the statement in therapy? And God forbid, if mom comes to the medical ICU, am I going to say, mom, no ECMO because the p-value is 0.07? It's going to be a tough call to make. You know, a lot of us, you know, James, I saw an interesting pyramid, you know, medical evidence, and I wish I'd put this up for the PowerPoint. At the bottom, you have your case reports, and then you have your case series, and then you have your observational studies, and then you have your randomized controlled trials, and then you have your systematic reviews and your meta-analysis. But right at the top, there's a small corner that's reserved. You know, it says, "I just know." And God knows there's so many things that we do here, you know. Like I said, is there a randomized control trial for transplant versus no transplant, James? Or CPR versus CPR?
Yeah, not officially, no.
No, there isn't any. So you see, so that's my rebuttal to that. You see, there are therapies that we do that, you know, if you were to say, hey, listen, show me the burden of the evidence, I would say, hey, listen, you know, ECMO probably has more evidence than transplant does. Would that be a fair argument to make? And what do you say for those 35 patients, or the 43% of the patients who survived when they crossed over? You see, so
yeah,
is that a fair rebuttal? Was that an unfair rebuttal?
Yeah, what I'm trying to get at is that if you have a study like this in the literature, then if we're at a center that advocates the use of VV ECMO for specific situations, you know, maybe we need to, you know, have a presence in the literature with observational studies that show where it is effective and where it does help.
James, but you know, one could imminently point out the weaknesses of the study. Like I mentioned before, you know, was this the absolute truth? It was an underpowered study at the best to begin with, and the study was stopped. It was an underpowered study to begin with. You see, if this study was done, you know, there was no confounding, there was no bias, and the study was done the way it was supposed to, and it had the power to come up with the conclusion that it makes, fair enough. I would not argue with that at all. But when the study was stopped midway, the numbers were not available to come to those conclusions. The authors go ahead and say so in so many words. And then the editor of the New England Journal of Medicine says, hey, listen, it's not positive in a traditional sense, but you cannot disregard the outcomes. What would you do? And at the end of the day, some of it is subjective, is because the patients who crossed over to the ECMO arm did so because the physician believed that these patients would improve. So that subjectivity, the art of medicine, truly comes into play, you know, I believe, when it's got to do with ECMO. At some point, you just got to bite the bullet, you know, roll the dice, and that's what you do, because that subjectivity was there in the trial itself. So for me, underpowered study, yes. You make a conclusion saying that it was not, that the p-value was what it was. But then again, I don't think all the endpoints of the study were met. Yes, if you powered it, then you make the conclusion. But as an underpowered study, can you truly say that? And for me, the absolute risk reduction truly makes a difference. And I walk away saying that, hey, you know what? ECMO did no harm. ECMO did not kill anybody. Some people who crossed over survived. And look, a majority of the patients in ECMO did survive with a PF ratio of 75 and with a PF ratio of 51. That's tough. That's tough, James. What do you think?
Yeah, I just think that if there's a study like this that's out there in the literature in a sort of a high-profile journal, there has to be some way to approach subsequent literature to show where the ECMO is effective, clinically effective, and you know, we need to continue to think about ways.
My best guess is James, is this, you know, just a matter of time before there's a meta-analysis with the EOLIA trial in, and then if one as an institute leader or as an economist would look into it, then my best guess is the study is going to be positive, because I think there's enough from the CESAR and from the EOLIA for you to, you know, to go over the line of effect. I'm quite confident that's what's going to be. The numbers favor a positive trial.
So, Sudhir, we don't have a lot of time left, but one thing that we kind of maybe touched on a little bit is, the EOLIA trial will likely never be reproduced given, the cost and all these different things. So, what's the best way to gain some of this this evidence that we're talking about here to try to convince people who may be on the fence about, ECMO?
Here's how it's going to be, Alex. The only way to convince for those of you who are sold out on this, you have enough. Like I said, for me, my glass is half full. You could take a look at the same study and you could take so many pot shots at it and say, well, I don't believe this. Or those of us who are there at the bedside who see patients walking away, getting better because you initiated the therapy, you're sold out on us. For a larger group of people out there looking into it, it's always going to come to that expert, isn't it? Hey, listen, my expert opinion based on the available literature is this, and everybody follows suit saying that, okay, fair enough, XYZ says so, it is what it is. But I would wait for the meta-analysis. If you truly want to hang your hat onto something, I would say a meta-analysis that includes the EOLIA trial. I think it's just a matter of time before someone is working on it. My best guess, someone in Toronto or EDFAN is probably working on it already. And you will have enough information over there to go to a body and say, look, hey, listen, the study is going to be positive. Look, and even if you do a meta-analysis, then you're going to find ways to make a hole in the meta-analysis and then still be biased towards it. We've already taken sides, Alex. That's not going to change. Those of us who do this, we are sold out on it. Those of us who don't, or in other institutions, not. But I promise you, irrespective of what the study is, if there's a patient decompensating in another ICU somewhere whose PF ratio is less than 75, I promise you and I are going to get that call. You know that for a fact, irrespective of what the evidence is.
That's true. And, they may not either believe in ECMO or don't have the capacity, but either way, transferring to, a center that can offer that, which was, shown in CESAR in and of itself to have, important impact on patient survival. So no, that's very much true.
Yeah.
Well, but I think what CESAR showed, though, I think as Sudhir alluded to, I mean, most of the referral and the treatment centers were not using state-of-the-art, lung ventilation strategies.
Absolutely true. Absolutely true.
So that was really the issue. It's probably different in the United States, I would conjecture. I don't know that literature, although not to open a can of worms, but Sudhir can comment. I mean, we found in our own ICUs that we weren't always doing that.
That is absolutely right, Dr. McCurry.
I want to speak out of turn, but at a high level, high functioning center in the United States, that we weren't always providing that therapy in our own institution.
That is very, very true. And this is true. So there's a study called LungSafe that actually looked at how patients in ARDS were being managed, and the rates of prone ventilation therapy being utilized is abysmal. And we know that even here in the medical. So when three years ago, when Dr. McCurry, Bala and I sat together in a room, there was an opportunity to do so many things, and it really gave us an opportunity for us to elevate the kind of care that we provide over here. And because there is a select group of us vested with this treatment and therapy right now, our adherence to low tidal volume ventilation, low Prato strategies, use of, adjunctive therapy has escalated dramatically. There's just no way there's a patient who's going to come to extracorporeal life support without any one of us having been invested with it. In fact, the COVID ICU was specifically set up, and it's the responsibility of the ECMO attendings to manage those patients. So right at the outset, that's how we, like a pseudo lung failure unit, you call it. But when it was initially pitched, the six of us took the onus of being the lead physicians for the COVID ICU, anticipating that we will have a bunch of cases coming through, and the six of us are connected to the region too. And what we've done is, over the course of time, what is really heartening is how the regional hospitals have picked up the gauntlet and have trained the staff to initiate treatment and therapy and connect to us. And just because we've created this service as a 24/7 service where a surgeon is available, a pulmonologist, a critical care pulmonologist is available, the J5 intensivist is almost always available, it's become so easy to connect, so easy to have an opinion, quick phone call, hey, listen, this is what I'm doing, this is what I worry about. If I think it's something that needs to be connected or to be told to my cardiothoracic colleague, then a phone call is immediately made. The intensivist there in J5, the connections are made. So I think tremendous effort from every department, HVTI, the cardiothoracic surgeons for all the support, and Dr. McCurry for your leadership, Bala for your leadership, and what the J5 intensivists are doing. It's tremendous what the group has managed to do. Nurses, the core group, Donna Tanner, Pat Grady, Alex Bribiasco, James June, core group, Penny from J3, tremendous work. I mean, to do an ECMO program, create a course, create a standard of education, ECMO Journal Club today, a multidisciplinary team meeting, writing our guidelines, helping our colleagues in Florida. Phenomenal, truly phenomenal.
Sudhir, I think we're out of time, but can I ask you one quick question, and maybe
Yes.
you can just educate the rest of us on this. So there's a lot of enthusiasm, at least in certain circles out there, about ultra low ventilation.
Yes.
Right. So traditionally, the ARDS trials show that, correct me if I'm wrong, this is the surgeon's viewpoint, but that ventilation with 60 cc's per kilo, limiting the peak airway pressure to 30, the plateau pressure to 30, was beneficial. But now there's enthusiasm for 4 cc's and even lower pressures.
Oh, absolutely.
So what's the status of that? And do you think that's going to change the picture here at all?
Dr. McCurry, give me a week's time and I'll come to you with the data, our mechanical ventilator data, because that's exactly what we've been looking at. We've been looking at 3 groups of patients. It's just a matter of time before I'll be able to come to the group with the data that I have right now. We looked at exactly that. The EOLIA study, and I didn't pull up that data that was there in the supplement, but EOLIA in the first 3 or 4 days targeted ultra lung protective strategy. So they were targeting 3 to 4 cc's in the first 3 or 4 or 5 days. And then as the ECMO run, extended, you would see the tidal volumes going up. So for our group, as a quality measure, for our group to embrace, ultra lung protective strategy, we need to know what the scope of our data is. And I think I'll be able to come to the group within a week's time to give an idea as to, hey, listen, during the course of an ECMO run, dividing into 4 quartiles, the first quartile, we had lung protective strategy, ultra lung protective strategy versus, unsafe mechanical ventilation. I will be able to give us those distinct numbers, and it's something that we can work towards, both in J3 and J5 if we so choose to.
But there are 1 or 2 ongoing clinical trials out there, correct? Correct me if I'm wrong, but I thought there was a trial in Europe or the UK doing ultra low
yes,
tidal line ventilation.
And using there is a REST trial that's going on right now.
Yeah,
absolutely.
Right. Yeah.
There's a REST trial with the eCore device using 3 cc's per kilogram per body weight to facilitate that. I think they've recruited about 800 and 900 patients, and the outcomes, I think about a year or 2 is when I think the study is going to be completed. But yes, the A-lung device is actively being employed in Europe, in the European market. The study is called the REST study, and the idea behind that is use of eCore for ultra lung protective strategy.
Any other quick comments?
Anybody? All right.
We stop there, or what do you think, Sudhir?
I think we are 8 minutes past 7 o'clock. Thank you everybody for your time.
All right. Thanks, Sudhir. And just a reminder, so Donna, you're still on, I take it. So the code Donna put in the chat box, but that's a 0, right, Donna? 9W0H9F.
Sudhir, do you still have the slide you can flash up real quick?
Yeah, let me
and it's also in the chat box, the Microsoft Team chat box. You want to look there as well.
Yeah, as I said, Donna put it up there.
Let me just see. Okay, wrong slide. Yep, there you go. Can you see that? Do you see it?
Yep,
yeah,
looks good.
Yeah, we can see it. Yeah, I think it's a 0, not an O. So 9W0H9F.
Yes, that's correct. It works.
Okay. All right, team.
All right, thank you.
Good evening. Stay safe.
Wonderful.
Thank you so much.
Thank you, Sudhir. Thank you, Ken.
Yeah, no, thank you guys. Thanks for putting it together, everyone.